Meningitis refers to inflammation of the meningeal layers that cover brain and the spinal cord. And there are two forms of meningitis: septic meningitis caused by bacteria, and then aseptic meningitis that has non-bacterial causes, like for instance caused by viruses, caused by fungus, tuberculosis, drugs, malignancy, and so on. And so basically, if here we have the brain, the first layer that covers the brain is called pia, the next layer is arachnoid, then we have the dura, and then finally we have the skull. And so meningitis is infection of the arachnoid layer as well as the cerebrospinal fluid that runs in the subarachnoid space. And these patients generally present with a triad of fever, nuchal rigidity, which is the same as neck rigidity, and then altered mental status. Other common findings include severe headache, as well as photophobia. Now here I would like to mention that while the classic triad of fever, nuchal rigidity, and AMS is described for meningitis, not necessarily all these signs may be present. So some of these signs may be present. And then headache that you see in these patients is not a typical headache. So it's actually very hard to miss headache caused by meningitis. And just to give you an example, while I was in my emergency medicine rotation in the 4th year of medical school, there was this young African American male that was admitted to the hospital for headache. And while I was trying to get history from him, he wouldn't answer my question. He would keep moving around from severe headache that he had, and he was kept saying, give me something for headache, give me something for headache. So I was telling him that, first I will have to get the history before I can give you anything. And he was like, okay, then move on, get on with it as soon as you can. So while I was trying to get history from him, he was covering his face with a towel, which made the history taking even more difficult. So I'm asking him, why are you covering your face with a towel? And he was like, the light is bothering me. So severe headache and photophobia in that patient gave me clues that the patient had meningitis. Next, I was trying to test for nuchal rigidity, see if the patient's neck is stiff. And as soon as I touched his head trying to lift it, he started screaming from pain. So basically, my point here is that signs of meningitis are kind of very obvious and it's difficult to miss them. Now, as for the nuchal rigidity, two tests that you will need to know includes the Kernig and then Brudzinski sign. So first you will have to know about the Kernig sign. So first we have the Kernig sign, where if you have the patient hip flex at 90 degrees, he's reluctant to allow you to fully extend his knee. And then the other sign is Brudzinski sign, where passive flexion of the neck causes involuntary flexion of the hip in these patients. And then one other important point I would like to mention here is that patients with encephalitis also have similar findings to meningitis in addition to behavioral changes as well as sensory and motor deficits. And then certain bacterial infections have their own features that is easy to distinguish. So for instance, patients with Listeria meningitis are at increased risk of developing seizures, while patients with Neisseria meningitidis have skin rash, like for instance petechia. And so the question that I have for you here is that what is the antibiotic that you can use for the treatment of Neisseria meningitidis? And the answer is ceftriaxone. Now the other question that I have for you is that for those close contacts, so for those individuals that have been exposed to the patient with Neisseria meningitidis, what kind of prophylactic treatment can you use in those close contacts? And the answer is rifampin or ciprofloxacin is used for prophylactic treatments of close contacts. Next, I would like to review the common bacterial causes of meningitis in neonates. So basically here, neonates from age 0 to 6 months are at increased risk of meningitis from group B Streptococcus, after that from E. coli, and then finally Listeria, is the third most common cause of meningitis in neonates. And the memory aid that I have for you is called bell. So ring the bell for neonates. So group B, Streptococcus. After that we have E. coli. And then finally we have Listeria. And then ignore the final L. And then in adults and elderly we have Streptococcus pneumonia, as well as Neisseria meningitidis as common causes of septic meningitis. And in elderly patients, since they're also having weakened immune system similar to neonates, they're also at increased risk of infection by Listeria, as well as aerobic gram-negative bacilli. So once again, adults are at increased risk of meningitis from Streptococcus pneumonia and Neisseria meningitidis. Teenagers in particular have highest risk from Neisseria meningitidis, and then in elderly patients, Streptococcus pneumonia, Neisseria meningitidis, Listeria, as well as gram-negative bacilli. Now I would like to mention that certain publications refer after age 50 for the increased risk of infection with these bacteria, while certain other books refer after age 60. So basically keep in mind, after age 50 to 60, and here I'm using a range because the different references use different ages. After age 50 to 60, Streptococcus pneumonia, Neisseria meningitidis, Listeria, and gram-negative bacilli are common causes of bacterial meningitis. Now here I would like you to note that both neonates and elderly are at increased risk of meningitis from Listeria. And so for the same reason, since the treatment for Listeria is ampicillin, we include ampicillin in empiric treatment of both elderly and neonates. So next I would like to discuss the antibiotics that we are using for empiric treatment of meningitis in different age groups. So the way I memorize it is that I start with a simple antibiotics to a more complex one. So first starting with ampicillin. Then after that we have the third generation cephalosporins, like for instance ceftriaxone. And then after that we have vancomycin. And so for neonates we are using ampicillin and ceftriaxone. For adults we are using ceftriaxone and vancomycin. And then for elderly patients we use all three of them. And here I would like you to note that ampicillin is included in empiric treatment of both neonates as well as elderly patients. The reason for that is that Listeria is a common cause of meningitis in both of these age groups. Now, next I would like to review aseptic meningitis. So as we just discussed earlier, aseptic meningitis is basically refers to non-bacterial causes of meningitis. And so viruses comprise the most common causes of aseptic meningitis. The common causes of viral meningitis include, for instance, enteroviruses, like for instance Coxsackie and echovirus, herpes simplex virus, mumps, as well as other viruses can cause aseptic meningitis. And these patients generally have an abrupt onset of symptoms of meningitis in addition to diarrhea, upper respiratory tract infection, as well as nausea and vomiting. And so this condition, the viral meningitis, is self-limited, and besides supportive treatment, you do not need to provide any specific antibiotic treatment for these patients. Then we have fungal meningitis. So imagine you have an AIDS patient that starts to present with symptoms of meningitis, and it's later on diagnosed with fungal meningitis. What type of fungal meningitis should you suspect in these patients? And the answer is Cryptococcus neoformans is a common cause of fungal meningitis in AIDS as well as immunocompromised patients. And so the next question that follows is that once you obtain the cerebrospinal fluid, what kind of staining can you use to stain for Cryptococcus neoformans? And the answer is India ink. Can be used to visualize encapsulated yeast organisms. Now there are other causes of aseptic meningitis, like for instance tuberculosis, Lyme, syphilis, and so on. There are drug causes of meningitis, like for instance NSAIDs, and then malignancy can also cause aseptic meningitis. Now, in order to exactly pinpoint the underlying infectious causes of meningitis, we will have to obtain cerebrospinal fluid. And so you know how the conus medullaris ends at the L2 level, so we can obtain the CSF by performing a lumbar puncture either at the L3, L4 vertebral levels or at the L4, L5. And you can use the iliac crest, which is shown right here, as your landmark, which marks the L4 vertebra. So if you go intervertebral level 1 above or below, will give you either L3, L4 or L4, L5. So either one of them you can use to withdraw the cerebrospinal fluid. So here you can see an example of the CSF needle going inside to the subarachnoid space where the fluid is drawn. So it's at the L3, L4 level. And so the CSF needle is a three-way needle that will draw the fluid. Then it's connected to the graduated cylinder, which gives you the distance in centimeter. And so depending on how high the CSF fluid will go up in this graduated cylinder, then you can measure the opening pressure of the CSF in centimeter water. So the distance here that travels the CSF up in the graduated cylinder, the other name for which is CSF manometer, will tell you the opening pressure of CSF. And the normal opening pressure is 7 to 15 centimeter of water. So 7 to 15 centimeter of water is the normal CSF opening pressure. And so once you obtain the CSF pressure, then you can open a valve here at the bottom to collect the CSF in the sterile plastic tubes and send them for analysis. So the first test that we would like to do on the CSF is a gram stain. And so gram stain will give you a lot of information about the type of bacterial infection that we are dealing with. For instance, let's say that the gram stain shows you that we have lancet-shaped gram positive daclococci. Could you tell me what type of bacterial infection are we dealing with? And the answer is Streptococcus pneumonia. Now, what if we have gram-negative daclococci? What kind of bacterial infection are we dealing with now? And the answer is Neisseria meningitidis. And then finally, let's say that we have gram-negative coccobacilli. What type of infection are we dealing with here? And the answer is Haemophilus influenza. Alright, so first we obtain the centimeter of water opening pressure of the cerebrospinal fluid, then we can obtain the gram stain, and then other important findings of the CSF includes the number of white blood cells that you will find in every microliter of the cerebrospinal fluid. So the normal value of this number of white blood cells in CSF is 0 to 5 in every microliter, which are predominantly made of lymphocytes. Then we have the protein concentration of between 15 to 40 milligram per deciliter, glucose of 40 to 70, and then the pressure we just discussed is 7 to 18 centimeter of water. Now, patients that have bacterial meningitis, the number of cells significantly increase, and they're mainly comprised of PMNs or neutrophils. There's an increased concentration of protein, decreased concentration of glucose in the CSF, and the CSF opening pressure is increased. We have similar findings with fungal meningitis. There are increased number of white blood cells, but here we have predominantly the lymphocytes. There is increased concentration of protein, decreased concentration of glucose, and increased opening pressure. And then with viral meningitis, there is also increased number of lymphocytes, increased concentration of protein, but the important finding is that the glucose concentration is normal. And then the opening pressure could be normal or minimally increased. Now, one important point I would like to mention here is that it's very important for you to know that both for fungal and bacterial infection, the glucose concentration is decreased, while for viral meningitis, the glucose concentration is normal. And so in the past, it was thought that bacteria and fungus use up all the glucose in the CSF, and that's the reason that the concentration of glucose is low. But then later research showed that actually these infections affect the glucose pumps that pump glucose into the cerebrospinal fluid. So regardless of what is the underlying cause of decreased glucose in the CSF, just remember that there is a decreased concentration of glucose with both bacterial and fungal meningitis, while with viral meningitis it's normal. So this is actually a very high yield table that you will have to know for your USMLE exam. And so examiners can give you information on the type of meningitis that you're dealing with. Like for instance, you obtain CSF fluid, the India ink shows you this finding. Now, what are the expected CSF finding? And then you will have to know that it's predominantly lymphocytes, the protein concentration is increased, or glucose is decreased. And then they may do it the other way around. They give you some information on the cerebrospinal fluid and then ask you what type of infection are we dealing with, whether it's bacterial, fungal, or viral meningitis. And that concludes our discussion of the meningitis topic.